Hello and welcome to Specialist Area Surgery at topic hernia. Let's start off with a few questions. Question 1. What hernia is most common in females? Femoral hernia, direct inguinal hernia, indirect inguinal hernia, or diaphragmatic hernia? A hernia occurs when an internal part of the body pushes through a weakness in the muscle or surrounding tissue wall. The answer is femoral hernia. Do you know the anatomical location of a femoral hernia? If not, we'll be answering this question later on. Question 2. What is a complication of hernias? Strangulation, weakened abdominal muscles, lump, or bowel sounds? The answer is strangulation. Strangulation leads to bowel obstruction, which can then lead to ischemia. Question 3. What type of hernia can cause GORD? The LOS weakens, so acid can reflux up the esophagus. The answer is diaphragmatic hernia. In this presentation, we will cover topics such as what is a hernia, the history and clinical examination, investigations and differential diagnosis, management and surgery, and some OSCE tips, with a few questions at the end to summarize. Let's start off with what is a hernia. A hernia is a protrusion of peritoneum through an opening, usually at the site of weakness. The main types are hiatal hernia, inguinal hernia, direct and indirect, and femoral hernia. You get other types of hernia such as obturator, epigastric, umbilical, etc. Some of the causes of a hernia are increased abdominal pressure, a pre-existing weak spot in the abdominal wall, straining, strenuous activity, pregnancy, or a chronic cough. Let's talk about the types of hernia. The first type we're going to talk about is in an inguinal hernia. We have two types, direct and indirect. For a direct hernia, older men usually acquire it due to an acquired weakness in the transversalis fascia. It protrudes through the inguinal triangle and grows through the superficial inguinal ring only, and it's medial to the inferior epigastric vessels. However, for an indirect, for males, it occurs in infants owing to failure of processus vaginalis and can form a hydrocele. It goes through the deep inguinal ring, then through the superficial, and then into the scrotum. And it is lateral to the inferior epigastric vessels. A femoral hernia is more common in females. It protrudes below inguinal ligament through femoral canal below and lateral to the pubic tubercle. A hiatal hernia, there are two types, a sliding and a rolling. 85% of hiatal hernias are sliding, while 15% are rolling. In a sliding hernia, gastroesophageal junction slides up into the chest, and is often associated with GORD. For a rolling hernia, gastroesophageal junction remains in the abdomen, but stomach rolls into the chest alongside the esophagus. As the LOS is still intact, the GORD is quite uncommon. In the history about the hernia, you have to ask for specific symptoms. For femoral or inguinal, is there a lump or bulge? Hiatus, do they get some reflux? And strangulated hernia, which would be a medical emergency, do they have pain, abdominal distension, nausea and vomiting? For the examination, and this examination does not include hiatal hernias, check for cough impulse. It indicates a communication between the intra-abdominal cavity and the lump. Check for obstruction. Do they have a distended abdomen or tinkling bowel sounds? And check for signs of strangulation. Is it red, tender, irreducible, pyrexic? Is the patient pyrexic, or are they tachycardic? Some of the investigations that you want to carry out are bloods, which is routine. However, you'd want to do a GNS as well in case an operation is likely. An ABG to check for metabolic acidosis for bowel ischemia. An abdominal chest X-ray for bowel obstruction, and an erect chest X-ray for bowel perforation. You might also want to do an OGD to investigate the possibility of a hiatal hernia. Some of the differential diagnoses for a hernia may be a lymphadenopathy, a hydrocele, lipoma, and abscess. For the management of a hernia, you might want to ask them to lose weight. You might want to provide them with guidance as well. You might want to treat the reflux, and if they have an inguinal hernia, supply them with a truss. This is supporting the herniated area using a pad and belt arrangement to hold it in the correct position. If surgery becomes a likely possibility, for rolling hernia, they should repair even if it's asymptomatic, as it may strangulate. For an inguinal hernia, a tension-free mesh known as the Liechtenstein repair. For a femoral, urgent surgery is required as there is a 50% risk of strangulation within 1 month. For an elective surgery, it's called the Lockwood approach, and for the emergency surgery, it's called the McEvedy approach. Some OSCE tips about when you present with a hernia. Make sure to check for signs of strangulation, as this may become a possible emergency. Maintain the modesty of the patient, as you will be exposing the groin area to examine the hernia. And check other hernial orifices, as if the patient has one hernia, there's a likely chance that they may have other sites for hernia. To summarize, let's answer a few questions about hernias. Question 1. Who is more likely to get a direct inguinal hernia? Older male, younger male, older female, or younger female? Remember, what's the mechanism of a direct inguinal hernia? The answer is older male. What are the causes of a hernia? Pre-existing weak spot in the abdominal wall, straining, strenuous activity, or pregnancy. Remember, what is the definition of a hernia? They are all possible causes of a hernia. Question 3. Rolling hiatus hernia is more likely to lead to GORD compared to sliding hiatus hernia. True or false? Remember, how does GORD arise? It's false. A rolling hiatus hernia is not likely to lead to GORD compared to sliding hiatal hernia. Remember, if the LOS is intact, then reflux is unlikely. Thank you very much for listening to this presentation.